Hello everyone, this is Dr. Humanist again. Let us now discuss about hypopituitarism. Okay, so first coming to the etiology. In the etiology, we'll see different categories. One is developmental or structural abnormalities. So, what are the causes? Midline cerebral defect syndromes, pituitary dysplasia or aplasia, primary epiphyseal syndrome, congenital hypothalamic disorders like septo-optic dysplasia, Prader-Willi syndrome, Bardet-Biedl syndrome, Kalman syndrome, congenital masses like encephalocele. Then coming to the genetic causes, it could be combined or isolated primary hormone deficiencies. Traumatic causes like surgical resection, radiotherapy damage, head injuries. Neoplastic causes like pituitary adenoma, paracellular masses like germinoma, ependymoma, glioma. Then Rathke cyst is there, craniopharyngioma, hypothalamic hamartoma, gangliocytoma, pituitary mets like from the breast, lungs or colon, lymphoma or leukemia or meningioma. Okay, these are the neoplastic causes. And then infiltrative or inflammatory causes like lymphocytic hypophysitis, hemochromatosis, sarcoidosis, histiocytosis X, granulomatous hypophysitis, transcription factor antibodies, and immunotherapy. Next, coming to the vascular causes, that is pituitary apoplexy or pregnancy-induced related or infarction or necrosis, subarachnoid hemorrhages, sickle cell anemia, arthritis. Next is infections. In fungal, like histoplasmosis, toxoplasmosis, tuberculosis, or pneumocystis cerevisiae. So, what are the clinical manifestations? So, depending on which hormone deficiency the patient will have the symptoms. So, it can be isolated or combined symptoms of all the hormones. Okay, there are 6 major hormones as we know. Growth hormone deficiency will cause what? In children, it will cause growth disorders. In adults, it will cause decreased muscle mass and increased fat mass. Okay, and next is gonadotropin, that is LH and FSH deficiency. In women, it will cause menstrual disorders and infertility. In men, it will cause infertility as well, decreased sexual function, and loss of secondary sexual characteristics. Coming to the thyroid hormones, so in children, it will cause growth retardation. In adults, it will cause all the symptoms of hypothyroidism like fatigue, weight gain, cold intolerance, and all. Coming to the ACTH deficiency, it will be adrenal insufficiency, like Addison's disease. There is a less impact on mineralocorticoid, that is aldosterone. And next is prolactin deficiency. It will cause failure of lactation postpartum after the delivery. Vasopressin deficiency will land up the patient into diabetes insipidus. There is abnormal increase in the urine amount, right? And coming to the investigation, so we have to investigate for each hormone. Okay, what are those tests? We'll see. So first one is for growth hormone. What you can test is, first is insulin tolerance test. So we'll induce hypoglycemia and we'll see the response of growth hormone, and it will be increase. No, so we'll see if it's there or not. So normal response is increased by more than 3 microgram per liter. GHRS test, after giving GHRH, we'll see the increase of growth hormone is there or not. So normal response is also same, more than 3. L-arginine test is also same, 30 grams will give IV over 30 minutes, and we'll see the response of increasing the growth hormone. L-dopa 500 mg per oral, and we'll see the response. Okay. Next is prolactin test. We have to give TRH. Okay, 200 to 500 microgram IV, and see the response by increase in 2 microgram per liter or increase by 200% from the baseline. Next is for ACTH, insulin tolerance test. In similar way, hypoglycemia will increase the cortisol levels, right? Even that is a stress hormone. So normal increase by 7 from the baseline or up to 20 microgram per deciliter is normal response. CRH test, you have to give 1 microgram per kg CRH and see the response of increase in ACTH. Normally it will increase by 2 to 4 folds and peaks at 20 to 100 picogram per liter, and even cortisol levels will increase more than 20. Next is meteropon test. 30 milligram per kg at midnight you have to give and see the response. So ACTH will increase by 75, and also 11 deoxycortisol will increase for more than 7.5. Standard ACTH stimulation test, ACTH is given, that is 0.25 mg, and see the cortisol increase by 21. Okay, and aldosterone by 4. Low dose ACTH we can give, that is 1 microgram IV, and see the response, that is same, more than 21. 3-day ACTH stimulation test also 0.25 mg over 8 hours IV, and you have to see the response of cortisol levels should be increased more than 21. For TSH, you can directly go for T3, T4 TSH and see the low levels of it, and TRH test. So you have to give 200 to 500 microgram IV and see the increase of TSH level more than 5 milliunits per liter. So same test we are doing here also, and even for prolactin. For LH and FSH, you can see basal levels of LH, FSH, testosterone, estrogen, or you can go for GnRH stimulation test. So after giving GnRH, that is 100 microgram IV, LH should increase by 10, FSH by 2. Now, instead of going individual one by one, you can do a combined test. You can give GHRH, CRH, GnRH, and TRH, and see the increase in growth hormone, ACTH, cortisol, LH, FSH, and TSH. Okay, that will be more easy, right? Now, coming to the treatment, the main treatment modality is hormone replacement. You have to replace the hormones which are deficient. So these are corticosteroids, thyroid hormone, sex hormone, growth hormone, and vasopressin. For ACTH, you can go with hydrocortisone, 10 to 20 mg per day in the divided doses. In that, 50% should be given in the early morning to resemble the normal physiological secretion of the cortisols. Next is cortisone acetate. Also, we can give prednisolone 5 mg in the morning. For TSA deficiency, as there is a hypothyroidism, you have to treat with L-thyroxine. The dose is 75 to 150 micrograms per day. Next is FSH and LH deficiency. So in males, you can use testosterone gel, 5 to 10 gram per day. Testosterone skin patches are there. Testosterone anthate, that is intramuscular injections once in 2 weeks, 200 mg. Females, you can use conjugated estrogen with progesterone. So we have to resemble the normal physiological cycle. So 25 days estrogen and then progesterone at 16 to 25 days, especially in the patients who is menstruating, whose uterus is intact. Other than that, estradiol skin patches you can use. And for fertility, you can go for menopausal gonadotropins because they are high in LH and FSH. Also human chorionic gonadotropins. Okay. Coming to the growth hormone deficiency, you have to use somatic.